What I'm going to do today is look at a general approach and warn you that the World Health Organization will have their new publication in 2016, and there will be over 100 different types of non-Hodgkin lymphoma. And hopefully we'll be able to define entities better and find targets that may be utilized for treatment as well as prognosis. We're in an exciting time. We just saw Dr. Coleman's talk about the use of brentuximab vedotin and the PD-1 inhibitors in Hodgkin lymphoma, and we're merging with a lot of new agents in B-cell lymphomas, which we'll address today in some of these entities. So I thought we'd look at follicular lymphoma, mantle cell, and diffuse large cell lymphoma. We'll mention the role of initial therapy in follicular lymphoma and the role of maintenance. In mantle cell, emphasize this rare indolent variant, the role of autologous transplant and maintenance therapy. And diffuse large B-cell lymphoma, we'll look at sites of origin, such as the mediastinum or the leg, skin, and double hit lymphoma, which is an emerging problem that we are now recognizing. And then conclude what's on the horizon in regards to lymphomas. As Mary indicated, I have no disclosures. I may discuss some entities that are either FDA approved for other diseases and that are being evaluated for new indications. So when we see a patient in our clinic, and I'm sure all of you do this, you walk into the room and you kind of go through this questions: who has it, what is it, where is the disease located, and we first look at the patient. That's the most important. That's the reason they're there to see you, and we call those patient features. The median age for non-Hodgkin lymphoma are in the 60s, so these patients tend to be old. We look at their performance status, whether or not they have B symptoms. And we look to see if they have any pre-lymphomatous conditions. So in pediatrics, they have a whole host of congenital disorders. And in adults, we're all familiar with the acquired conditions, including HIV, organ transplants, autoimmune diseases, inflammatory bowel disease. And then we try to look at, is there any role for an infection that may be playing a part in the lymphoma, such as EBV, hepatitis B and C, H. pylori, HTLV1. And those can play a role in not only diagnosing the disease, but how it's managed. Probably the most important thing is the pathology. And again, 100 is going to be too many for us to remember, so we try to simplify it. And the cell of origin is either going to be a B cell or T cell. And the 80-20 rule is that usually 80% plus is going to be of B cell origin, and less than 20% will be of T cell origin, unless it originates in the skin. We still use grade because that simplifies for the clinicians kind of how the disease may behave: low, intermediate, and high grade. And there are only two high grade: Burkitt lymphoma and lymphoblastic lymphoma, usually of thymic origin. And we treat the latter with ALL, and we usually use intensive therapy for Burkitt lymphoma. Ideally, for every cancer, you want a genetic marker that defines the disease. And for many of the B-cell lymphomas, we look for translocations involving chromosome 14, which define the disease. For the T-cell lymphomas, we don't have as many. The best that's been used is the 2,5 translocation associated with T-cell anaplastic large cell lymphoma. And then the third question we ask is, where is the disease, the stage? And we use PET scans, CT scans, and sometimes and often bone marrows, and whether it's limited stage 1 or 2 or advanced stage. And we look at LDH. Of course, the higher it is, the worse the prognosis, and the number of extranodal sites. And we're all familiar with the International Prognostic Index, the mnemonic APLES: age, performance status, LDH, number of extranodal sites, and stage. And almost every lymphoma has now developed their own prognostic index. It's all modified, but the more adverse number of features you have, the worse you're going to do. So the mantle cell one's called the MIPI, the follicular one's called the FLIPI, and the peripheral T cells called the PIT. But they're all kind of similar. And so we're going to look at follicular lymphoma. And this summarizes an expanding list, and it limits, the numbers on this are much larger than what are listed. But watchful waiting is going to be used less and less, but it's an older generation doctor still thinks it's valid because there's no hard data that early therapy improves overall survival. Radiation therapy can be utilized, particularly if the rare patient who has local disease, but it's being used less and less because of the new effective therapies. We all know the success of monoclonal antibody therapy with rituximab, but there are a bunch of new ones coming down the pike. For advanced disease, chemoimmunotherapy, that's chemotherapy plus rituximab, have been the standard therapy. We have all these new novel agents which are effective in the B-cell lymphomas, ibrutinib, idelalisib, lenalidomide, and we'll talk about some of those, but the problem is trying to figure out how to introduce them into therapy. Radioimmunotherapy is taking less of a role. It's kind of complicated. Bexar is no longer available, and we still have Zevalin. It's effective therapy, but why we've not used it in part is because we don't get the profits, I suppose. But it's a very effective treatment to still consider for selected patients. And stem cell transplant's always been controversial in the low-grade lymphomas, both autologous and allograft. And the ultimate immunotherapy are still vaccines, and there's ongoing research looking at that type of approach. Well, this is an important study which was a non-inferior study to see if bendamustine plus rituximab was not inferior to R-CHOP with indolent and mantle cell lymphoma by Rummel, and it was published in Lancet in 2013. The median progression-free survival was longer in the BR arm compared to R-CHOP, 69.5 months versus 31.2. BR was better tolerated with no alopecia, less hematological toxicity, less infections, and less stomatitis. There were increased erythematous skin reactions more commonly in the BR than in the R-CHOP. But this is being used more now than R-CHOP for some of the low-grade lymphomas. A randomized trial looked at rituximab, and this comes out of England. The first author is Ardeshna. It was presented at ASH in 2010 and published in Lancet Oncology in 2014, but basically these were asymptomatic, non-bulky follicular lymphomas, the type of patients many people might watch. And they randomized to observation, Rituxan times 4 doses only, and Rituxan times 4 doses followed by Rituxan every 2 months times 2 years. And the progression-free survival was better for the latter at 81% versus observation at 33%. It's not clear why they closed Arm B, but they did close it. They said something about people didn't like getting randomized to that. It's a little odd, but the results in time to initiation of new therapy, if you look at this, the top curve is Arm A, which is the rituximab, and they obviously don't need new therapy because they're on some therapy for a while and they get some long-lasting progression-free survivals. The Arm B looks as good as Arm A, and remember they closed that early so they don't have numbers on as they do on the other, and Arm C looked inferior for progression-free survival or initiation to new therapy. However, there's no difference in overall survival. And this looks at, Brad Call from ECOG reported this trial, which was comparing rituximab maintenance versus retreatment. So basically, this is Arm B versus Arm A of that last trial. So just 4 doses of rituximab, and then you watch the patient, or you put them on rituximab and maintenance. And the median time to treatment failure was similar at 4 years. The 3-year freedom from cytotoxic therapy was inferior in the retreatment arm, but very few actually had to have a lot of retreatment. And if you look at the median number of rituximab doses, it was 18 for maintenance versus 4. So I think this suggests that you can use rituximab when needed and that you don't have to have rituximab maintenance. When I asked Dr. Ardeshna, did he worry about the cost of rituximab, he said, no, the government pays for it, and I don't have to worry about that. But that was Britain. This is looking at some other studies questioning the use of rituximab. The long-term follow-up of patients with follicular lymphoma receiving single-agent rituximab at 2 different schedules. And this was a randomized trial looking at rituximab times 4 doses versus 4 doses followed by rituximab every 2 months for 4 more doses. And these were both treated and untreated follicular lymphomas. This had long follow-up. The median event-free survival was 13 months for rituximab arm versus 24 months for the prolonged arm. In the untreated group, event-free survival at 5 years was 22% for the rituximab times 4 versus 45% for the prolonged arm, with a p-value 0.045. But again, no difference in overall survival. And one other study looking at rituximab maintenance for 2 years in patients who had received chemotherapy. The chemotherapy was selected by the physician, and at the time, R-CHOP was the most commonly used, 885 versus RCVP at 272, and only 45 received the fludarabine, cytoxan, mitoxantrone arm. And then these patients end up being randomized for either no further treatment or Rituxan. And up in that top left corner, the progression-free survival, as expected, is superior for rituximab maintenance at 74.9% versus 57.6%. However, in that bottom right curve, there's no difference in overall survival. And if you start to look at adverse events in people on Rituxan maintenance, the adverse events were more commonly seen in the maintenance arms, 56% versus 37%. There are more infections, the immunoglobulin levels are down, so there's more sinusitis, more pneumonias, and the grade 3-4 adverse events were also higher at 24% versus 17%. So I do have some objections to rituximab maintenance. It doesn't matter too much, it's still being used a lot, but I think you at least have to consider these. It is expensive. The optimal maintenance schedule and duration are still unknown. We never really reached the maximum dose needed in rituximab, and there's some suggestions that higher doses are a little more effective for men more than women in large B-cell lymphoma. There is this increased risk for neutropenia, hypogammaglobulinemia, infections, and progressive multifocal leukoencephalopathy. There are black box warnings for the latter. It doesn't tend to happen. It's infinitesimal chance. But when it does happen, your life is over. And the patient it's going to happen in are patients who are heavily treated and have gotten a lot of rituximab. There's no single trial has shown improved overall survival for rituximab maintenance in follicular lymphoma. And retreatment at progression, the Brad Call study, is not inferior to maintenance in regards to overall survival and success. Some might argue that if you used a ton of rituximab, you may become more chemo-resistant, and there's no hard data that that's true, but there is always some concern about exposures to agents. So let's look at lenalidomide and rituximab in non-Hodgkin lymphoma. So this is a trial across all the low-grade lymphomas, and it basically used lenalidomide and rituximab at both induction, and then you could receive Rituxan and lenalidomide for maintenance for an entire year. But the overall response rate across the board was 80% for small lymphocytic lymphoma, 89% for marginal zone lymphoma, and 98% for follicular lymphomas, with complete remission rates higher in the latter at 87% and less so in small lymphocytic lymphoma, as you might see in CLL. But the PR rate in SLL was good at 53%. So you have this tremendous response rate using non-chemotherapy in the indolent non-Hodgkin lymphoma. And there's going to be a new international study where they're going to have 1,000 patients in follicular lymphoma, and they will be randomized to lenalidomide, Rituxan versus chemotherapy plus Rituxan for the induction initial 6 months phase, and then randomized between lenalidomide, Rituxan maintenance versus just Rituxan maintenance. And this is an important study because it may be that low-grade lymphomas won't need traditional chemotherapy depending upon the results. Let's look at another new agent, idelalisib, and this is a selective oral inhibitor of the PI3 kinase pathway, and these were patients who were called double refractory. That means they'd seen rituximab and alkylating agents. They received 150 milligrams twice a day until progressive disease or toxicity, and the primary endpoint was overall response rate, and the secondary endpoints were duration of response, progression-free survival, overall survival, and safety. And this looks at the median age at 64 years, bulky disease in 47% had over 5 centimeter masses. The majority of patients were follicular lymphoma at 58% and small lymphocytic lymphoma at 22%. And the median number of prior therapies was 4, so these were heavily treated patients. And this was reported in the New England Journal of Medicine by Gopal in 2014. And the point of this study is looking at the adverse events, but the main adverse events are neutropenia. Any grade was 56%, grade 3 or 4 at 27%. Transaminitis could occur in up to 48%, in grade 3 or 4 and 12%. You could stop the drug and then reintroduce it. And clinically for the patients, diarrhea is a problem, and up to 13% had adverse 3-4 severe diarrhea, and you can have severe colitis. So this is a drug that is reasonably tolerated, but 20% of the patients discontinued treatment due to the adverse events. And this was the conclusions. Relatively well tolerated, acceptable safety profile, and was active in double refractory indolent non-Hodgkin lymphoma. The overall response rate was 57%, with 6% CRs. It was across all histologies, number of prior regimens, refractoriness to bendamustine or tumor bulk. They continued treatment with idelalisib, led to durable responses greater than a year. The median duration of response was 12.5 months and progression-free survival at 11 months. So another new agent for B-cell lymphomas. Let's turn to the mantle cell lymphoma. Almost everybody, every now and then, will see what looks like CLL, and it may be mantle cell. That's why you need flow cytometry to make the diagnosis. And this indolent form occurs in up to 15% of mantle cell lymphoma. They tend to have non-nodal disease, and they often present with lymphocytosis and splenomegaly, a clinical feature just like CLL. The potential identifying markers is that they do not have a complex karyotype. They have a low-key 67%, often less than 30%. They have a high level of these IGH variable chain mutations and lower absent SOX11 expression. And you can approach them just like CLL. You can initially observe median survival exceeds 7 to 10 years. You may be able to give them less aggressive therapy, because our knee-jerk reaction when we hear mantle cell lymphoma is to be aggressive, and I'll address that next. But these patients may be able to be approached like CLL without aggressive therapy. And this next is where we usually think of mantle cell lymphoma. So young people in middle age and even elderly can tolerate hyper-CVAD. It's harder the older we are. And this was generated by MD Anderson, had a 93% overall response rate, and they followed it by autologous transplant, and the 3-year overall survival was 92%, and event-free survival is 73%. When they added rituximab, this similar high response rate, 97%, 87% CRs, and they omitted transplant in most of those patients with a 10-year overall survival at 64%. Another group has alternated maxi-CHOP, so dose-intensive CHOP, alternating with high-dose Ara-C. It looks like Ara-C is an important part of therapy for mantle cell lymphoma, plus rituximab, followed by transplant. Again, a very good overall response rate over at 96%, event-free survival at 63%, the median event-free survival at 7.4 years, and the overall survival and relapse-free survival exceeded 10 years. Another group has advocated R-CHOP times 3, followed by R-DHAP with the Ara-C and platinum times 3, followed by transplant. Again, very good event-free survival, 6.9 years, and 5-year overall survival of 75%. Just as I told you, I'm not a big fan of maintenance, but when I make a statement like that, along comes on all these trials showing that maintenance does improve overall survival in mantle cell lymphoma. So this was reported in New England Journal of Medicine in patients who were not going to be transplanted, usually because they were older. And it was basically a fludarabine-based regimen versus Rituxan CHOP, and they had similar CR rates, but shorter 4-year survival for the fludarabine-based regimen at 47% versus 62%. But maintenance therapy with rituximab improved overall survival compared to interferon, which was another maintenance regimen. But this suggested that there may be a role for rituximab maintenance in mantle cell lymphoma. Bortezomib has been approved for mantle cell lymphoma, and we're trying to figure out how to use it. So these are 3 reports. First, using it with bendamustine rituximab in relapsed refractory indolent and mantle cell lymphoma with an 83% overall response rate and 52% CR and 2-year progression-free survival at 47%. The next trial is very important because basically it indicates bortezomib plus Cytoxan, adriamycin, prednisone, and rituximab is better than R-CHOP. And this was just reported in the New England Journal of Medicine. In the abstract form, the progression-free survival was 24.7 months versus 14.4 months, and the overall survival was 64% versus 54%, favoring the introduction of bendamustine to CHOP, basically replacing vincristine. Bortezomib hyper-CVAD-R was an ECOG trial, so this introduced bortezomib and rituximab, followed by rituximab maintenance, and the overall response rate was 95%, complete response 68%, progression-free survival 72%, and overall survival at 88%. There was no difference in progression-free or overall survival between patients treated with maintenance or those who got transplanted. So this suggests maybe you don't need to transplant mantle cell lymphoma if you introduce both bortezomib, dose intensity, and rituximab. Looking at lenalidomide, again, it also has been approved for mantle cell. It initially had a 28% overall response rate. The median overall response was 16.6 months. The median progression-free survival was 4 months and overall survival of 19 months. And now it's being used with rituximab in relapsed mantle cell lymphoma with a 57% overall response rate and 36% CR. And now it's being used in frontline therapy for patients who are ineligible for transplant with a 77% overall response rate and 40% complete remission or CRU. And right now there's a new regimen being utilized in elderly patients with bendamustine and lenalidomide, and with a 93% overall response rate and a CR rate of 79%, and progression-free survival of 74% at 2 years, and overall survival of 87%. So another new agent effective for mantle cell lymphoma. Ibrutinib, also approved. Phase 1 trial, response rates at 60%, including 7 of 9 patients with mantle cell lymphoma who had 33% CR. In a phase 2 trial for relapse, response rates at 68% and 21% CR with 47% PR. So again, a very effective agent. And now how do we use it with other drugs? And this is a phase 1b study of bendamustine plus Rituxan and ibrutinib with an overall response rate of 94% with 76% CR. And there's an ongoing phase 3 trial comparing bendamustine rituximab with or without ibrutinib for frontline mantle cell lymphoma. So there's a whole host of new agents. It's an exciting time in B-cell lymphomas. As I mentioned, the idelalisib is being evaluated, mTOR inhibitors, temsirolimus and everolimus. There is an auroric A kinase inhibitor, elasertib, and that's been effective in B-cell lymphomas, about a 20% response rate, but has a 40 to 50% CR rate in peripheral T-cell lymphomas. ABT-199 is directed towards BCL2, thought to be important in germinal center lymphomas. Obinutuzumab may be better than rituximab in CLL in a randomized trial with chlorambucil, ofatumumab, epertuzumab targeting CD22, milituzumab targeting CD74, and polatuzumab vedotin CD91179B, which is on a reasonable number of large B-cell lymphomas. And with that in mind, as you heard, the success of brentuximab vedotin, this is a phase 2 trial that was just reported, and they had 48 patients who were CD30 positive diffuse large B-cell lymphoma with a 44% overall response rate, including 17% CRs and 27% PRs. And the CRs were durable with a median duration of 16.6 months. There was no difference between relapsed and refractory patients, and responses were seen in other B-cell lymphomas, including 1 CR, 2 PRs in what's called in 6 gray zone lymphoma patients, 1 CR out of 6 primary mediastinal large B-cell lymphoma, which even though the numbers are small, it's a little surprising because those are CD30 positive, and 1 CR in 3 post-transplant lymphomas. There was no statistical correlation observed between response and CD30 expression, but all responding patients had quantifiable CD30 by computer-assisted immunohistochemistry. So let's look at diffuse large B-cell lymphoma at sites of origin, and that's the way B-cell lymphomas have often been defined, where they start. So the mediastinal large B-cell lymphoma has traditionally been treated with R-CHOP plus minus radiation. There's some data that R-EPOCH may be able to decrease the need for radiation. Testicular lymphoma, R-CHOP, after an orchiectomy, radiate the contralateral testicle, and you have to give them CNS prophylaxis. Primary cutaneous lymphoma of the leg, R-CHOP plus minus radiation therapy. CNS, which are large B-cell lymphomas, high-dose methotrexate plus minus high-dose Ara-C, and rituximab. Radiation tends to be delayed at this point, but can be utilized at some point in the treatment. And there is a question about using autologous transplant up front, and then a rare type of B-cell lymphoma called intravascular B-cells, and these tend to be in older people. All you see is a little purplish discoloration of the skin. You biopsy the skin, and you see these large B-cells invading the blood vessels, and they can have CNS involvement. What's unique is that many of these lymphomas have MYD88 mutations, often seen in activated B-cell lymphomas, and ibrutinib works in a number of these, and it crosses the blood-brain barrier in CNS lymphomas. So diffuse large B-cell lymphoma, we not only have these sites of origin, but it's a heterogeneous disease. And by immunohistochemistry, a relatively crude way is to separate them out into germinal center B-cell by their immunophenotypic markers. So CD10, a follicular marker, will push a person into the GCB-like. If you're CD10 negative and BCL6 negative, you're going to be activated B-cell. An intermediate step, if you're BCL6 positive but MUM1 negative, you get to be a germinal center one, and MUM1 positive puts you back into activated B-cell. This is an important distinction because by genomic profiling, we have at least 3 different and probably 4 or 5 different types of diffuse large B-cell lymphoma, with the primary mediastinal B-cell lymphoma having the best survival. And these patients, when you look at genomic profiling, they share the same genetic data as Hodgkin lymphoma, so a lot of clinical overlap as well as genetic overlap. The germinal center B-cell type, about a third of them will have the classic 14-18, but they involve genes around the germinal centers. The activated B-cell has different gene profile, and they have a worse prognosis. And about a third will have mutations in the MYD88 gene. And so this is different diseases defined at a genetic level, but for us clinically, the activated B-cell lymphoma has had worse survival. Lenalidomide with diffuse large B-cell lymphoma, looking at cell of origin, has a much better response rate if you have the non-germinal center, the activated B-cell. And the overall response rate was 52.9% versus 8.7% in the germinal center B-cell lymphoma. And this was statistically significant in progression-free survival of 6.2 months versus 1.7 months. And if you start to add lenalidomide to rituximab CHOP on the right, then the differences between germinal center and activated B-cell lymphoma start to disappear. Ibrutinib similarly is efficacious in the activated B-cell type. So these are patients very refractory. The overall response rate for activated B-cell was 41% versus 5%. and they had CR rates, and the median overall survival was 9.8 months for ABC subtype versus 3.4 for germinal center subtype. So those agents are going to be added to diffuse large B-cell lymphoma. What I'll do is conclude with a rare problem, what is called the double hit lymphomas and double expression. And the double hit refers to the MYC824 translocations in combination with another translocation, usually BCL2, but it can be BCL6 or others. Double expressor is different. It refers to positive protein expression detected for MYC and BCL2. And MYC amplification, greater than 4 copies of MYC, also has an adverse prognosis. MYC rearrangements are different between B-cell lymphomas. So Burkitt lymphoma is defined by MYC translocation, and classically as the 814 translocation, or the MYC gene will translocate to where the light chains are located. Does not have a complex karyotype. You don't see these other translocations. They have almost 100% key 67, and double hit lymphoma doesn't occur in Burkitt. What's called the gray zone, B-cell lymphoma undefined, which is in between Burkitt and diffuse large B-cell lymphoma. The MYC translocation is in 35 to 50%. It may be with the classic chromosome 14 or another gene. There's a complex karyotype. They often have the BCL2 and BCL6 translocations. The key 67 is high, but it's not usually 100%. Double hit lymphomas occur in the gray zone lymphomas frequently, 30 to 70%. In routine diffuse large B-cell lymphomas, the MYC translocation may be found in 5 to 15%. Doesn't have to be the partner chromosome, so it can be with the other non-immunoglobulin gene other than chromosome 14. They have a complex karyotype. About a third will be with will have BCL2 translocations, a third may have BCL6 translocations. The key 67 is variable, and the double hit is somewhere between 2 to 10%. When you look at double expressor, with on the top curve on the left where they do an immunohistochemistry stain, greater than 40% MYC, on the right it was less than 70% BCL2, but on the lower panels when they had greater than 40% MYC, this was a patient who was clearly double hit by cytogenetics, so had MYC translocation and usually a BCL2 translocation. So MYC was present, and they had greater than 70% BCL2 expressor. So that is the way this might look on immunohistochemistry. And why I threw this in here, I don't know. But that was for T-cell lymphomas. But just to say that DUSP22 is equivalent to 2,5 translocation. So double expressor large B-cell lymphoma is similar but not equivalent to the double hit lymphoma. So double expressor, they use these cutoffs. It's in 21 to 34% of diffuse large B-cell lymphoma. Less than 20% are double hit lymphomas, and 63 to 76% have the activated B-cell type. The outcomes are inferior to large B-cell lymphoma but superior to true double hit. And the double hit lymphomas are in that 2 to 5 to 15% of diffuse large B-cell lymphomas. Most of the time it's less than 6%. 80 to 90% will have double expressors, and near 100% are of germinal center B-cell origin. Normally we think that's a better disease. So this study looked at the difference between patients who had neither expressor or double hit, and if you had neither of those, what was called other, your survival is over 60%. If you were double expressor, the overall survival was 36%, the progression-free survival was 32%, and if you were true double hit, your overall survival was 27% and your progression-free survival was 18%. And this just looks at a trial that two of my colleagues, they're hidden in this numerous, Dr. Nishita Reddy and Judy Sai, collected ours, and we shared our data of double hit lymphomas in 15 academic centers in the United States and Canada. And there was no difference in overall survival between patients who received R-CHOP and those who received other intensive regimens, about a 40% survival, but there were adverse prognosis factors. So if you had advanced stage, lymphocytosis, a leukemic counterpart, LDH more than 3 times normal, and CNS involvement, the survivals fall off markedly. But with respect to R-CHOP, if you compare each intensive induction regimen, they did do better with progression-free survival. And that includes R-Hyper-CVAD, dose-adjusted R-EPOCH, and R-CUDOX-M, which is a pediatric Burkitt protocol. So stem cell transplantation, however, was not associated with improved survival following first complete remission. There's a trend, but if you achieved a complete remission with whatever regimen you used, with some data, the more intensive ones, you may not need to add stem cell transplant. So on the horizon, it is likely that most B-cell lymphomas can be treated with chemotherapy-free regimens. As more effective agents are incorporated into therapy for mantle cell lymphoma, the role of autologous transplantation will likely diminish. Double hit and double expressor diffuse large B-cell lymphoma have a poor prognosis. More intensive regimens than R-CHOP appear to be warranted. And harnessing the immune system through novel monoclonal antibodies and chimeric antigen receptor T cells may overcome resistant cells. I just want to show you this last slide from Steven Rosenberger's group at the NIH looking at the chimeric antigen receptor T cells, which have been utilized for chronic lymphocytic leukemia and acute lymphoblastic leukemia and can be used in diffuse large B-cell lymphoma. So they had 15 patients. This is called a second-generation anti-CD19, which contained a CD28 co-stimulatory moiety. They would take the T cells and it would take them about 10 days to produce the autologous peripheral blood CART cells. And the mean peak CART-positive T cells occurred after infusion between days 7 and 17, and majority were CD8 positive. They achieved CRs in 4 of 7 diffuse large B-cell lymphomas, and 3 are ongoing. This is a toxic approach. The grade 3-4 toxicities, high fevers, they can have this cytokine release storm. In 2 of the patients they used tocilizumab, an antibody to interleukin-6. The neurologic complications are quite impressive, 40%, and they can be confusion, aphasia, and obtundation. All are reversible. But this is a very efficacious therapy, but its off-target toxicity is so severe it's isn't ready for prime time. But we're in an exciting time for B-cell lymphomas as well as Hodgkin lymphoma, and that's what I'd like to conclude with. Thank you.